This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya del Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction practice. This podcast offers Category 1 CME credits through MyCare and Michigan State University. The links for the CME are in the show notes. This week, we are going to be discussing alternate dosing of nicotine and varenicline after failure of the initial doses. How are you doing tonight, Sonya?
I'm doing really well. Today in clinic, I got to present the very first Introduction to Evidence-Based Medicine lecture for our new interns and our returning residents. I love that lecture. We talked about the Peacock questions and the JAMA User's Guide to the Medical Literature. So, life is good.
That's exciting. Yeah, I was in clinic today. I had a student with me, which is always kind of fun. And I always think it's a big win when the students come back, like just to kind of request to come back out to hang out. I feel like they really kind of enjoy coming out, especially the day we do our MAT clinic and our kind of addiction treatment. So it's kind of fun.
Hey, I had a student in the office earlier in the week who worked with you. She said you were really cool.
Good. You know what? You know what a student is for a doctor? It's the closest thing you'll ever get to a yes man, right? Because like they like kind of follow you around all day. You could say like the craziest stuff and they kind of have to agree with you because you give them an evaluation. You get like no real feedback of reality. So I'm like, you start to talk about crazy stuff and they're like, yeah, you're right, Dr. Keenan. That's great. And deep down, they probably are cringing, but
they laugh at all your jokes. Like suddenly you're really funny.
You're like the coolest guy. You're so funny. I mean, it's really great. Medical education rocks. Students.
We really respect you. Sorry about this, but we appreciate the good vibes you bring.
Yeah, it's super fun. How about you? Anything else fun going on?
No, looking forward to the holiday weekend. I did have something I wanted to share with our audience in addiction medicine, though. It's not really addiction in the news, but I come across resources sometimes I just really like to share, and they were really interesting for me as a clinician because, I work with people who are in treatment for opioid use disorder. I'm not like with patients when they're using drugs. I don't actually know a lot about the ins and outs and the practical details of how one uses drugs, and I came across two resources about safer drug use. So one was from the Yale program in addiction medicine and one from a group called the San Francisco AIDS Foundation. And both of them provide really good kind of non-alarmist information about the risks of drugs. So they don't say drugs are good. They say drugs are bad and they provide information about the risk. But they also explain ways to use drugs safely and ways to minimize those risks. So anyone out there listening, I'll put the links in the show notes, but they're great resources for clinicians to review and great information to give to your patients. And, so you may not be comfortable telling your patients how to use drugs. That might feel a little bit anathema to what you're out there to do, but you can give them these links. And as I said, it contains very sort of measured information. It tells people if you're going to inject or smoke or use drugs, all drugs in any way, how to do it safely, how to minimize the risk of infection especially. So I just thought these two resources were really cool, and I'll put them in the show notes for everybody to look at. John, do you ever counsel your patients like they're using drugs? Do you ever speak with them specifically about how to use drugs safely?
Can I be honest with you? Not kind of any of like the quote harder drugs. I mean, I think that kind of like tobacco with secondhand smoke exposure. I think we often talk about that. Medical marijuana is legal in my state, and certainly in adjacent states, recreational marijuana is actually legal as well. I do talk to them about kind of like best practices there, if there's such a thing, especially kind of with risk of impairment with driving, which is kind of a large portion of our local drug court at this point. Our local DUI court is basically impairment from marijuana containing or THC containing products. So I do talk about things like that in terms of like safe injection techniques and kind of the more kind of higher risk drugs. I'll be honest with you, I haven't. I think though, that's not like I'm not willing to do it. I just don't have a bunch of patients that are like, that come to see me all the time that are kind of like actively engaging. Most of my selection bias is people that are trying to stop doing that, right?
Well, right. And I tell people, especially when I'm giving out naloxone, I'll say, just in case, they're all like, I will never need this. And I say, I hope you never do. And so a lot of patients, especially when they're in treatment and doing well, they don't really want you to lecture them about how to inject drugs. That's not what they want to hear. I've started to do some, though, because I have patients, I'm seeing a lot at my clinics of methamphetamine use. So I have a lot of people who are doing great from an opioid standpoint. They're really doing good staying off the fentanyl, but they're continuing to struggle using methamphetamine. And I've started to sort of talk to people a little bit about, like, yes, I know they're using it. Yes, here's when and how. Yes, here's what you can do to protect yourself, moving forward if you're going to use it. So I have started doing some of that counseling with people. And I think the patients have found it very affirming in that I'm not out to kind of catch them or punish them for drug use, that it makes them feel like we really do want to help them. So I don't know if they take my advice or not, but I think it helps show them that we're, as providers, we're in their corner and we really want the best for them no matter what they choose to do.
Yeah. That's interesting.
Anything strike your interest in addiction medicine news this week?
I thought it was interesting, especially the New York Times, but actually the CDC has a press release about this. I don't know if you saw that they've done a recall of kind of a commercially available psilocybin containing product called Diamond Shrooms. Did you see this at all in the news?
No, tell me about it.
So basically, this is a psilocybin company, and they basically produce kind of different things, some of which also includes like hemp-derived, like CBD, THC, and basically they're kind of like removing from the market or doing a withdrawal of that kind of many products containing psychoactive compounds, both cannabis and kind of mushroom extracts are basically being recalled. And this was after kind of this case series where they've had like 39 serious injuries linked to these products, 23 of which were involving hospitalization, seizures, and while no deaths, they did talk about people who were ventilator dependent after kind of exposure to it. And they basically talk about kind of these sub-products that are kind of in the Diamond Shrooms chocolate bar and also the Diamond Shrooms birthday cake chocolate bar, which is kind of like most likely leading to this. And they don't quite understand why, if it's contaminant or related to the primary source. But it's interesting that they have kind of launched this kind of CDC and FDA kind of ban. We're getting a recall here on this product. And I don't know. I think most of us now have seen THC containing products, certainly like, kind of like commercially labeled like edibles, and certainly have patients that bring these to appointments and we have to kind of talk about not leaving them on the countertop. But on the flip side, some of these kind of like psilocybin containing products, certainly I'm seeing more of this with people kind of talking about that they're getting these kind of commercially available products that are mass distributed by these kind of small select states that are allowing psilocybin to be kind of commercially distributed. And a lot of times it's in these edible forms where you are supposed to kind of like self-guide yourself through an experience. So if anyone has any Diamond Shrooms products at home, please be careful.
Toss them in the trash.
Yeah.
Well, I think patients are shocked to learn that products that are sort of supplements or something like, hallucinogens aren't FDA monitored or regulated. Like, it's like a food. You can sell it, and if there's a problem with it, then the, FDA can work to recall it. But it's a big project. It's hard to recall a product. And all the stuff it says on the package about how it works is just like marketing.
Yeah. He'll be interested to see kind of like as we kind of see more legalization of some of these drug products, and they have kind of these, these indications, whether it's like medical marijuana with its kind of multiple indications, many of which lack substantial evidence. Or now we have kind of like, psilocybin is kind of the new marijuana where it's kind of being legalized for medicinal purposes. Although kind of the data shows this kind of utilized with kind of counseling. I have a feeling like this is just going to be people using psilocybin. We'll just have to see what the health ramifications as a society is that we see.
Yeah. Yeah, it'll be interesting. I'll be interested to see what happens over the next 20 years that I hope to be in practice.
On a side note, I actually had a patient just this week that was a young adult. This is in my general clinic, and they weren't that young, to be quite frank. and they were reading about how you can quit smoking with psilocybin. So they've just been going into the woods and taking some illicit mushrooms, thinking that will help them quit smoking. And I kind of directed them the article, like, that's not really how that works. And so they were quite appalled that like they thought you just like took it and that was how it worked. And so it's interesting, like kind of lay perception already isn't even there, right? They don't even kind of understand where the limited information comes from or how it's being used and utilized in limited situations.
Yeah, I mean, I don't know. I just know some people with some, plenty of people with positive experiences, but some with some significantly negative experiences with hallucinogens. So I'll be interested to see how it plays out and what products remain legal and which ones are sort of found to not be safe for general consumption.
Yeah.
So on that note, would you like to hear about our article?
Yeah. Let's go.
All right. I'm super excited because, we always look for articles that will change our practice. And I really think this one will change my practice for sure. So the title of this article is Smoking Cessation After Initial Treatment Failure with Varenicline or Nicotine Replacement. And it was a randomized clinical trial. It was published in JAMA in May of 2024. So a pretty new article in a major journal. A little bit of background about smoking. So 11.5% of the U.S. population are current smokers. So a historic low, but still 11.5%. And 60% of those smokers will die from a smoking-related illness. So tobacco use has the highest mortality of any of our substance use disorders, 60% mortality. Of those people who smoke, about 70% want to quit. So most smokers want to quit. And 55% have made a serious quit attempt, meaning that they went at least 24 hours without smoking in an attempt to quit smoking. So about half of smokers really have actively tried to quit. However, only 7.5% of those succeed at each quit attempt, and only 4.7% received evidence-based therapy to assist their quit attempt. So, people are trying to quit, but they're not really receiving therapy that would help, that's been proven to help, and each quit attempt has a pretty low success rate, about 7.5%. So because these smoking cessation attempts are often unsuccessful, the average number of quit attempts is about 6 prior to achieving sustained abstinence. And there's really minimal research about the best strategy after a failed quit attempt. Like, what should you do next if you try something and it didn't work? You were not able to quit smoking. So, John, do you feel like most of your smokers want to quit?
I'd say the majority do, yeah. I'd say about 70% sounds about right for what I see. Most do. There's some people we talk and they have no interest, and I just don't kind of understand the motivation, or oftentimes when they're there for tobacco-related complications in an office visit.
Yeah. All right. So, clinical question. The clinical question here is, what is the best subsequent strategy after a failed quit attempt with varenicline or combined nicotine replacement therapy? Should you continue with the same medicine? Should you switch to the other medicine? Or should you get a higher dose of the medicine you started with? So a very kind of practical clinical question. If someone is trying varenicline, it didn't work after 6 weeks, should you continue the varenicline for 6 more weeks? Should you switch to nicotine, or should you get varenicline but at a higher dose? And the same with nicotine replacement. Population in this study, it included 490 people, and they were all people from a Texas tobacco treatment clinic, so people who obviously want to quit smoking if they're in this clinic, connected to the MD Anderson Cancer Center. It was adults who had to smoke at least 5 cigarettes a day. And this was confirmed by exhaled CO2 levels. They had to speak English, have stable housing, and have a phone to participate in this study. Exclusion criteria was anyone with basically unstable psychiatric disorder, so psychosis, mania, suicidality, active substance use disorder. Basically, if you were mentally unstable, you could not be in this study. The demographics were 43% female, 58% were white, and 26% were black. The mean age was 48.1, and they had smoked on average a pack a day for an average of 28 years. So these are people long-term, pretty heavy smokers at a tobacco cessation clinic in Texas who want to quit. And so they did 2 interventions. First, either you got varenicline, 2 milligrams a day, which is the standard dose, or nicotine replacement therapy, so a 21 milligram patch plus 2 milligram lozenges up to 6 a day for 6 weeks. So you got either varenicline or nicotine. That was randomized. If you hadn't quit after 6 weeks, then you either got an increase the dose of the medicine to varenicline 3 milligrams a day, or double your nicotine patch to 42 milligram patch and lozenges, or you could switch to the other medicines. So you could switch to nicotine from varenicline or switch to varenicline from nicotine. And it was compared to standard of care, which is just continue the same medicine for another 6 weeks. If it didn't work for the first 6 weeks, just continue varenicline or continue nicotine. They also all received a weekly counseling session, a brief counseling session about smoking cessation. The outcomes, primary outcome was self-reported and CO2 confirmed 7-day abstinence at 12 weeks. So 12 weeks was the major outcome point. Had you quit smoking or had you not smoked for at least 7 days? Secondary outcomes, which would be considered more descriptive or exploratory, were continuous abstinence at 30 days and finally continuous abstinence at 6 months. Did the smoking cessation persist? Did it endure for 6 months? But the main study outcome was over about 12 weeks. So, John, what do you think of the clinical question?
I mean, it is interesting and a really common scenario that we see, right? I mean, like people that kind of, quote, like fail a treatment, kind of where we're going to go with that after that point in time. I think if you go off of like what we currently have, it's like, let's try this, let's try A, and then B, and then C, and then back to A, and then to B, to C. And it's like, it's very cookie cutter. There's not a ton of different variability. So I love the idea of kind of looking at kind of salvage. What is a better salvage regimen for this group that doesn't respond to our first line?
What do you do if someone's on varenicline for, let's say, 6 weeks and they haven't quit smoking?
What do I do in practice? I mean, I ask them if they, like, how much they're smoking, if they've decreased their smoking. I do have people that go from like 2 packs of cigarettes down like half a pack of cigarettes. And oftentimes as a risk mitigation, I'll just continue for another 2 months, kind of reassess and see how they do. I have continued people for much longer than the 2 months. Like, I think a lot of the trials are 8 to 12 weeks that I've seen. But like, anecdotally, I'd rather you smoke a quarter pack than 2 packs of cigarettes daily for a medicine that you're tolerating.
Have you ever used varenicline 3 milligrams a day or nicotine 42 milligrams a day?
Never.
Well, we'll see how it turned out.
We'll see how it goes.
Right, we'll see. So, is this a valid trial? First, some strengths. It was randomized, stratified by race and gender, placebo-controlled, double-blinded trial, so that's awesome. The statistical analysis was really designed to model clinical sequential decision-making, and they used what's called a Bayesian approach, and that estimates the probability that a treatment would be successful. And that really, again, models what we do in practice. It was pretty big. There were 490 people. They estimated they would need 500 to reach the power that they wanted, so they got pretty close to the number of patients that they wanted initially. The groups were similar at the start of the trial. The participants were remunerated, like they were paid. I don't know if that's good or bad, but they were compensated to help them stay in the trial because, there were a lot of study visits. All groups received equal interventions other than the study medication, and because it was placebo-controlled, everybody received pills, patches. You couldn't tell what treatment you were receiving. The results were clinically significant, I thought, which was smoking cessation, and it was confirmed objectively as well as subjectively. They did report on adverse events, which is really important because this is an off-label use of both of these drugs. And they did an intention to treat analysis for those patients who didn't complete the study, which was quite a lot. And adherence was the same in both groups, so people didn't drop out more in one group or the other, which is important if you're worried about side effects. So a pretty strong trial. There were some limitations. One is that it was short-term, just 12 weeks. Also, because in the end, there were 6 groups, and that basically meant a small number of people in each group. So that reduced the sort of power of the study. The doses they used were off-label, so some people might be uncomfortable using nicotine or varenicline at these doses because it's not officially labeled that way. And they also had a lot of people lost to follow-up, so a large percentage of patients did not return for re-randomization. And if you didn't show up for re-randomization after 6 weeks to say if you'd quit smoking or not, you were just assigned to continue your initial treatment. And then after re-randomization at 6 weeks, a lot of people were lost to follow-up. So 87 were lost to follow-up, even though they were given significant payment for being in the study. The other limitation I thought of is that the most effective treatment is varenicline plus nicotine, sort of, from other studies, and that wasn't actually included here. And finally, about considering financial influence, Pfizer did supply the varenicline and the matching placebo pills. Other funding was from the Cancer Center grants, and I think was unlikely to cause bias. I don't think the Pfizer providing the varenicline would necessarily cause bias, but as we talked about before, if there's drug company funding, it does lead to publication bias. Like Pfizer's not going to put money into a study that they don't think is going to get published and is going to show their drug in a good light. So it's not that the study was wrong, but there might be other data that is not as good for varenicline, which never comes to see the light of day. So do you think it was a valid trial, John?
I mean, that seems like it's about as good as it gets, right? So randomized trial. I understand there was some minor to moderate kind of industry funding, moderately good size of 490 people, similar groups. Yeah, I understand your kind of point about kind of the gold standard being combination varenicline plus nicotine replacement. I will say this seems more real world, though. I don't see that often, that frequently, even though it is like supposedly the best in the literature. I've never utilized the combination therapy. Mostly patients are buying into it, and I don't see a ton of people having ever tried a combination before.
I always offer combination, but a lot of patients are not interested because they're already not so into taking medication. And then to have to take two at once, they're like, they think they won't need it. So,
Yep.
But no, I think it was a pretty good trial. So let's talk results. So basically, I'll quote the authors. They said, for individuals who smoked but did not achieve abstinence after treatment with varenicline, increasing the dose enhanced abstinence compared to continuing. Whereas for non-abstainers initially treated with nicotine, a dose increase or switch to varenicline enhanced abstinence and may be viable rescue strategies. So the strategies that work, if you started with varenicline and you didn't quit at 6 weeks, you could increase the dose. If you started with nicotine and it didn't work, you could increase the dose or switch to varenicline. Those were the three groups that did better after not quitting for the first 6 weeks, the three strategies. So let's go into the numbers a little bit. In general, in the nicotine group, there's a 99% posterior probability that either strategy, either switching to varenicline or increasing the dose, would confer benefit over just continuing with the initial dose. In the varenicline group, there was a 99% posterior probability that continuing varenicline at the initial dose was worse than switching to higher dose, so higher dose was better. There was also a secondary outcome of continuous abstinence at 6 months, so that was sort of an exploratory outcome. And the only thing that led to continuous abstinence at 6 months was increased doses of the nicotine and varenicline that provided benefit over continuation of the initial treatment. So really the most effective as you continued on, although again, that's an exploratory outcome, was doing the higher dose of the nicotine and the varenicline. So I summarized the results from the table on a really nice chart that I put on a PowerPoint slide, which you guys can't see because this is audio, but I will share it on social media. If you want to join our Facebook group, I'll put it up. But just to talk some specific numbers, because I thought this was super interesting. So people who quit initially, like people who took nicotine and were abstinent at 6 weeks, if you made it to 6 weeks, about 78% were abstinent at 12 weeks. With varenicline, if you made it to 6 weeks, about 72% were abstinent. So the nicotine came out a little bit ahead of the varenicline in this trial, 78% for nicotine and 72% for varenicline if you were successful at 6 weeks. And then at 6 months, so these are people who were quit for basically 3 months. At 6 months, 39% of the nicotine patients were still abstinent and 40% of the varenicline patients were still abstinent. So basically the same amount. So it gives you a sense of the efficacy. If you are able to quit at 6 weeks, about 40% of people will be able to maintain that for 6 months. So that's good, and same with nicotine. It's not 100%, so people will relapse, but it gives you a sense of how effective these medications are. For the group who can't quit, remember, we either left them on the same medicine, switched them to the other medicine, or gave them the high dose. To me, the high doses are the most interesting. So people who started with nicotine and were not able to quit, if we increase their nicotine dose, 14% had quit at 12 weeks. And at 6 months, about 6% remained quit. For people on varenicline, if they hadn't quit and then they got the increased dose, about 20% were able to quit at that point with the 3 milligrams a day of varenicline, which is really good. And 2% were still quit at 6 months. So that wasn't great, but it was better than all the other groups. So not fabulous numbers, but if you consider a habit with a 60% mortality, if you can get 2% of people to quit, that's awesome. So, anything is helpful, especially for a medicine like varenicline that has relatively few side effects. So again, the strategies that really I feel led to improved quit rate was the higher dose nicotine and the higher dose varenicline. You also got some benefit if you were on nicotine and you switched to varenicline. That did provide some benefit at 12 weeks. They talked about adverse events as well. The only adverse event that was really attributed to the medication was nausea in 22% of patients for varenicline. Just, John, to let you know, there was no flatulence reported. At our previous article about, varenicline for vaping cessation, a lot of patients reported flatulence, and we sort of opined on whether we're going to have to add that to our counseling. According to this study, you can take that out again.
Just the one author, right? The one author, the one study. I've never seen or heard that anywhere since then, but that was like a third of the patients or something like that.
Flatulence. Does it show that we're not mature enough if we think farting is funny?
The students would laugh.
We also talk about abnormal dreams. That's a very feared side effect from varenicline, and about 15% of patients had abnormal dreams, but it was in both groups. It was not worse with varenicline than with nicotine.
Interesting.
So I wondered if maybe it was just from the nicotine agonism, because varenicline is a partial nicotine agonist as well.
That is interesting.
It is interesting. And of course, remember, if you're wearing a patch or taking varenicline, you have nicotine agonism overnight, which you don't have if you're smoking. So I sometimes call people out on the little, like I've taken medicine that causes abnormal dreams, and it's a little disturbing. You don't feel necessarily rested when you wake up, but it's not terrible. And the idea that people would reject smoking cessation because they might have abnormal dreams for a while, I'm like, well, your 60% chance it's going to kill you versus a 15% chance of having an abnormal dreams for a few months. Do you think we could try it anyway? But people really fear that side effect. And then finally, just a little bit of other information in the trial. I thought it told us the initial success rates of both nicotine and varenicline at standard doses was pretty good. And the adverse effects of the high doses was minimal. There were very few side effects. And as I said, nausea and abnormal dreams for high-dose varenicline. And that's with the high-dose off-label use. So really minimal side effects. John, what do you think of the results?
I mean, it definitely is something I'm going to consider now in terms of it seems like very limited harm. This is a group where we don't have there's a lack of other options, right? So I feel like we're often trying things kind of seeing what sticks. I think I'm going to offer the higher dose varenicline to some patients off-label in the future that are failing. Now I'm going to cancel it's not FDA approved. This is off-label use of this dosage, but I think most people would agree to that.
Yeah. I also like the data about the nicotine patch. I mean, there's this sort of popular conception that if you smoke with the nicotine patch on, you're going to have a heart attack and die. And these people just slapped on 2 nicotine patches. They doubled it. Forget just smoking a cigarette or 2 with the nicotine patch on. So they really went all out. So it makes me more comfortable. I already tell people if you have to smoke with a nicotine patch, just smoke. Smoke 1, smoke 2, leave the patch on. But if you're going to smoke the whole pack, maybe take the patch off. And now I feel like I don't even have to say that,
Yeah. I've never said that. Although I always had the patients take it off at nighttime. I've never had them keep it on throughout the evening.
Interesting. I have people just keep it on all the time so that they don't wake up and have to smoke first thing.
Interesting.
Maybe that's why they're having abnormal dreams.
I don't know where I learned that from, but now that I'm thinking about it, but I will tell you that's my practice for that. And I thought that was a thing. Maybe I'm wrong.
We'll have to look it up. We'll report back to our audience. Let's do a poll right now. If you do smoking cessation, do you have people take their patch off at night, or do you just leave it on around the clock? So, are these results going to help me? My patients are definitely similar to those in this study. I have access to all the treatments that were evaluated. I'm not sure insurance is going to cover these off-label doses, but I'm willing to give it a try. And nicotine patches, of course, are over the counter. The benefits of the increased doses was increased quit rate, and the harms were pretty minor, and then cost. Also, it's more expensive if you're going to use 2 patches a day or have to pay for your varenicline out of pocket because insurance won't cover it. The benefits, I think, are worth the harms because the harms are pretty minimal. For increasing the dose for staying on the initial dose, I calculated the number needed to treat to achieve abstinence at 12 weeks is 16 for nicotine and 5 for varenicline. So for patients who are on varenicline, it doesn't work. The number needed to treat is 5 if you switch them to the higher dose, which is pretty good for a smoking cessation intervention. For nicotine, number needed to treat is 16, which is still pretty good, although not as good as varenicline. So in conclusion, if I have patients who have not been successful after trying nicotine or varenicline for 6 weeks, I'll offer a higher dose of the medication, or for nicotine replacement, a switch to varenicline. And I'll also be able to reassure patients that the side effects are pretty minimal. I definitely will be using this, I think, as a strategy moving forward.
That's a great article. Certainly, I feel like smoking cessation is something we keep covering. And every time, like, are we doing this again? And like every time I feel like we learned something kind of new, which is like, it seems like it's the least like exciting of our addictions, but it truly is the one that probably even more so than kind of opioids definitely has an impact in terms of general health on our population.
It totally has a huge impact. I mean, it's a low drama addiction. There's not a lot of crazy behavior, getting arrested, running around, skipping visits, all this stuff people do with other addictions. It doesn't cause a lot of drama for us, but it is so bad for you and the mortality is so high. And people do want to quit, Even people who say they don't want to really do a quit attempt, if I said, if you had your choice, would you wish you were a non-smoker? They'll say, yeah. They wish they never started. So.
Yeah.
I think there's a great opportunity here.
Yeah, great article. Thanks for presenting that.
And I want to hear our listeners' thoughts. If anyone uses this strategy, 3 milligrams of varenicline especially, please let us know. I'm interested to hear how it works.
Well, thank you for that article, Sonya. Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook group. The links are on the show notes. Original theme music was composed and performed by Benjamin Kennedy, audio editing by Aaron McHugh, CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.